Hello everyone, this is a podcast of one's own, and I'm here today with our president Esther.
Hello.
And our treasurer / events manager Aurora.
Hello.
And we're going to talk about gender bias in medicine today, or the health gap, as you put it in the title for the session. We're going to basically speak about how women are often not offered the same treatment as men, or more often misdiagnosed, and we're also going to speak a little about racial bias and bikini medicine, a term that I wasn't really familiar with before, but we're going to enlighten you and explain what exactly it is. So yeah, you two had held the session. Do you remember who came up with the idea of talking about? I think it was you, Esther.
I think it was me, yeah. It's something that I'm really interested in because it upsets me so much. The more I keep reading about it, it's one of those really, really clear, people don't really think that it's a big thing because legally a lot of people perceive that we have all the same rights, but then all this bias comes into it, and when it comes to health, and especially healthcare, clinical healthcare, when there's a gap like that, that really sets the people that are getting the short end of the stick at such a big disadvantage, actual death. It's such a sharp contrast.
I didn't really at first I was kind of like, what are we talking about here? Is it how male or female patients are treated differently by doctors, or is it about the treatment they get? But then I started sort of noticing certain things when I just scrolled through Twitter or I read the news, and then I read one article saying that apparently last year 8,000 women in the UK, I think, died because from a heart attack or a heart disease that was not acknowledged for what it was, because the symptoms are different for men and women, and because the male body is sort of the default in clinical trials or in research. And I couldn't believe it. I was how? I mean, obviously, and I feel maybe we should start by sort of explaining the difference between sex and gender again, because I feel this is kind of important here.
It does make it so when we started the session we were talking, I felt I had to point that out, because there's a whole other section of it that is about the transgender and non-binary experience in medicine, which is such a massive contrast to anything that cisgendered people experience. But since we're talking about clinical trials and body physiology, there's historically it's been divided between the two sexes, and I mean the health gap that we're talking about is the misalignment between what's actually the division of the two the two different body types, male and female, and not understanding that they function differently in certain diseases. So it became kind of a session that was a bit it was quite cis-centered and heteronormative, but that's also the way that clinical health science works, unfortunately. But I mean, one of the take-home messages I think as well is that while socially we should try to not put that big of an emphasis on sex and focus on gender, because that's what we're performing and that's what we choose and that's what we identify as. But in health we have to acknowledge that there are physical differences, and I raised this idea this what's called gender blindness, which is just treating all patients the exact same regardless of sex or gender, and which is going to be difficult because based on your gender you're going to have different social experiences and different social pressures that have formed you into being more vulnerable to certain diseases or experiences, mental or physical. And when it comes to sex, if we just ignore that there are physical differences between sexes, then a lot of things are going to go unnoticed, like heart attacks in women, for example, because the symptoms are totally different from men.
We watched a video where a doctor, I think she explained some of the differences. For example, one thing that she brought up was a prescription for
Ambien,
which is supposed to help you sleep.
Mm-hmm.
And then only recently they found out that the sort of doses they prescribe, the prescription, it's been on the market for decades, right? And the prescription was just like, it was way too much for most women.
To have the dose, the dose for women, because women digest it slower due to like specific due to the like makeup of female hormones. And
it could be really dangerous when they're drowsy in the morning because they've taken too much, they get behind the wheel, might cause an accident. And I couldn't believe it. I was like, these like things, these pills, they go to like so many stages of being approved till they're finally released to the market. So why did no one intervene? Like, why did no one say anything?
It was like Aurora was bringing up some of the clinical trials that have been done as well, and I can't now remember exactly what it was, like what diseases they were on, but they had like these massive sample sizes of like 22,000 people or 13,000 people, and they had zero women. Like there were only men in those trials, which is to me fucking it's baffling crazy. Because it's like, what's the point? Just do like literally just do 50-50. But
it's also the fact that they had to like, what was it? Was it 8 out of 10? Something like 8 out of 10 pills or something on the market had to be taken back because they hadn't been properly tested on women.
Yeah, because
but then they had like bad effects on women, but they hadn't noticed before because it mainly just been tested on men, which just seems ridiculous. Why go through all of that process?
It is on male animals when they
male cells,
male cells, male animals, and then male humans, and then
expect the same to happen.
And why do you think? Why do you think they don't test on women? Is it for medical reasons, or is it because the people in research are predominantly male and just not really interested, or why?
We were talking about this, and historically it was to protect women, to not do anything that could potentially harm them. Like you're in a clinical trial, you don't really know what's going to happen. And historically, I think that was we found when we were doing the research that it was kind of justified by women are gonna we can't gamble with their bodies because they need to be able to have kids. Like we need to protect. What if something happens in the clinical trial and they can't have babies? And that was the way people justified it in the past.
I think
then obviously
it was also kind of shifted to women's bodies are too complicated.
Yeah.
So because hormones fluctuate too much, and it's just
it's crazy.
I'm like, why do you not want to understand that though?
Yeah.
Why do you not want to help half of the population?
And how do you if you already assume women's hormones fluctuate too much, why do you not also assume medicine is gonna work differently on men?
Yeah.
I mean, it's also
there seems to be
one of the most shocking things to me is birth control designed for women to take was developed on based on male hormones. Of course it's gonna be wreak havoc in the female hormonal system, and it already does in males. But then it came out to the market, and it doesn't really matter because men don't have to take it, and
And they also had that one trial that was looking at breast cancer, and they just tested that on men.
Yeah,
which was kind of
but
what? Why?
But it's also, I think, the idea that women's hormones are so inconsistent and unpredictable. I mean, those are hormones, but it's the same for men. Literally, it fluctuates in the same way as it does for women.
Yeah,
and there's just this sort of stereotype that hormones make women crazy or hysterical, and that's actually very deep rooted. Since ancient Greek, I think, this sort of stereotype that the uterus is something that wandering the body and goes into the brain or something. And it's shocking how we still have these sort of stereotypes when we're in a conversation with people, mostly men, but as we talked about yesterday with Jamila Jamil, sometimes it's even another woman who says calm down, don't be so hysterical.
I mean, in terms of that, the way that hysteria is playing a role is, we were talking about it, how so many women experience misdiagnosis based on that stereotype, and that still lingering belief that women are hysterical, even though people don't actually think that the womb is wandering around the body anymore. There were studies made to see what the risk factors were of getting a diagnosis for a mental illness, and they were either being previously diagnosed with something like psychosomatic, or just being a woman. That was a risk factor, not in developing the disease, but getting diagnosed with it. And misdiagnosis is one of the biggest killers in the world, because obviously if you get diagnosed in the wrong way, you're not going to get the right treatment. And women, so much more than men, get not just rightly diagnosed with psychosomatic diseases, but misdiagnosed with them as well. And I think the fact that, and this is not just things that I'm saying, obviously we did the research, so statistics show that men are much more likely to not just be taken seriously at in the first encounter with doctors. They're also much more likely to, doctors will interpret their symptoms as organic, something that's actually happening in their body, whereas women are going to be
told
they're going to be told that it's psychosocial, or it's something, it's stress. And I was shocked to see that a lot of women women are much more likely for, and this is the key part, for the same symptoms of the same severity. So it's not different levels of intensity or whatever. It's the exact same severity of the same symptoms. Men are more likely to get advanced clinical care and treatment, whereas women are more likely to be prescribed self-care. But just go home and take it easy.
But don't you think that another part that sort of plays a role in this is also gender? We talked a lot about sex, but how does gender sort of influence the way we talk about our illness or our disease? Because I remember you, on one of your slides, it said that men are more
men are what was it?
Leave it alone.
Men are leavers alone, and women are worriers.
So that would actually, that doesn't really line up, because then I would say women are much more likely to be hey, there's something actually wrong with me, you have to treat me, while men are just kind of nah, I'll go next month.
I think they're it's interesting to bring that in. That's why I put it there, because that was a social study on the way people talk about health and the way that it gets to them. And I think maybe women worry because for other reasons, not necessarily worry in the sense that they will go to the doctor, because a lot of people, women, will not want to go to the doctor because they know that they won't be taken seriously for a range of reasons. And there are so many intersectionalities coming into it. There's racial bias, and there's fat phobia, that people are just gonna dismiss any of your symptoms just because you're
just
in a larger
lose
body.
Weight.
And that will stop people from coming into doctors as well. But just in the way that people talk about it. And I think that was a really important thing to point out, just in terms of what toxic masculinity plays, or how that plays a role in it as well. Because obviously there's a whole, we focused in the session mostly on maybe physical diseases that are misdiagnosed for mental illness, but for men as well, they are much more likely than women to commit suicide based on being depressed, because it's something that they don't feel comfortable talking about. And people go just misdiagnosed for long, if they go through diagnostic investigations, if nothing organically is wrong with them, then it might go unnoticed that they have a mental problem. And that's another side of the coin that's really, really dangerous.
So when we talk about toxic masculinity, for everyone who's not sort of familiar with the term, it's a way of performing gender for men.
Here to macho culture.
Yeah, macho culture. And it's not just higher suicide rates, but also just a higher mortality for men. Men are likely to die earlier than women. They tend to suffer from heart disease, or just like shorter life expectations in general, and also like things like alcohol abuse, which could be seen as like a sort of a symptom of toxic masculinity or repressed emotions.
Yeah, I think so. That's
and maybe diet also plays a role, because if we're talking about macho culture, it's always like, oh, you need so much protein, like you need to eat meat, and then obviously that leads to heart disease. Like you don't have to be a scientist to see a connection there. So you can see how like gender plays a role in like how you treat your own body, how you talk about your symptoms. But you just mentioned racial bias in medicine as well, and I think it's really important to talk about that as well, because I was shocked. I mean not that shocked, because we all know that racism is like ingrained in our society, but patients of color are undertreated for pain, so they are 22% less likely to receive opioids in emergency rooms.
Yeah, like
and if you're in an emergency room, it is pretty urgent.
And that's obviously just coming from social prejudice and stereotypes about Black people just not experiencing pain in the same way as white people do. I'd say it stems from the idea of like savagery and you know like which is just like so fucking ridiculous that this is still like in our system. There was one study of medical students,
that was shocking.
like 200 medical students that were given a bunch of false statements about differences between races, and one of them was like black skin is thicker than white skin, or something like things or like Black people don't have the same nerve sensitivity as white people or whatever. And 50% of those medical students, these are people that are going to go into the field and become doctors in emergency and surgery and everything. 50% of the students thought that more than like I think it was at least one, or like I think it was 1 to 10 statements, like more than half of them at least thought that some of them were right. And I think that's absolutely ridiculous. Like that's really, really dangerous.
It is ridiculous, but it's also, when I said before I found it shocking. I mean, I find it shocking, but it's also not very surprising. Like if you think about it, it's just, I mean, we're all white, so we don't experience racism. We've never experienced, because on a side note, there's no racism against white people because of their skin color. That's not a thing. I hear it all the time. So I just really want to clarify that no white person is ever discriminated for being white. That's just not a thing.
They were also mentioning how when they did these studies, they thought that it was also like an age thing, depending on like there are other confounding variables, but that they did the same evaluations on kids, and these are children, where I think they said 2 out of I can't remember the statistic, but Black children are like likely to wait as maybe twice, I think it was twice as long as white children for
to see a doctor.
To see a doctor for like appendicitis, something that's like really emergent.
And also another statistic that you brought up is that Black women are 5 times more likely to die during childbirth.
And that's in the UK. Like I think the others, I'm not sure where the opium one's American or whether
And that's the
so it's
that's
like you
the
somehow
UK.
associate that with the US maybe, but
It's
I mean we know the UK is not amazing, but it still was like
at least we have public health care.
But then you still see that it's 5 times.
But then likely. There's an intersectionality as well, because like obviously those are mothers, so they're women. And they're Black. So
like the intersectionality of that is just, and then imagine being a fat Black woman, like the amount of discrimination and like misdiagnosis and like just invalidation you're gonna go through. Like trying to get help for something that you don't know what's wrong.
And I feel like
I understand that people don't want to go to the doctor.
Exactly,
you know
that's what I was going to say. I feel like those experiences can be so traumatizing that you are very likely to just not go, or to just sort of try to treat yourself. And I mean here you can just get painkillers anywhere basically.
Yeah.
In Germany, it's like you have to go to a pharmacy. You can't just buy them in a supermarket, and they're gonna tell you, don't take more than like 3 pills or whatever every day. And here it's just like so easy to just buy painkillers and basically just avoid going to the doctor that way. So let's talk a bit about bikini medicine. Because that's a funny word. I had never heard it before.
I think it's really telling of what it is. It's really like the way that medicine emerged when like starting to take into account the female body, but falling short on in a lot of different ways by basically saying that the female body functions in the exact way as men apart from boobs and vagina. So like your genital area and your boobs, like that's like the bikini medicine that we were talking about.
Okay.
So that's what was ever investigated when there was something specific to women. But other than that, the male model's still been used for all other aspects of.
It's so ridiculous. I have a cousin in Germany and she studied medicine, and she was telling me about how when she went to medical school, how in like all the books you read, when a disease is described or symptoms are described, it's like it only talks about the male body, and then it sort of has a footnote saying like, women might react differently to the treatment, or like women might show different symptoms. And she said you actually have to go in and like actively look for resources and like research to like tell you how is it different?
That's so dangerous as well, because that's going to make it more likely that medical students don't have as a comprehensive idea of women's medicine. Even like, I mean, that would already be the case because the research is not there. But even what is there, if that's not accessible, that's going to make the like ability to provide correct care to people, like half of the people. Like it's not like a tiny little, like it's half of the people. Like,
you cannot even blame like medical students for it, because like how are they supposed to recognize certain symptoms if they've just never learned about it? And those are people who like, they're going to be doctors. They're going into healthcare, and
I think it was like for the example of heart attacks. I think it was they had done a study on female heart attacks and like
how the symptoms different. Do you remember?
It was the statistic they found was that women are 7 times more likely to be sent home from hospital in the middle of having a heart attack. While they're having a heart attack, they're sent home because they can't find anything.
Because the thing that
7 times more likely.
Or what I think I know about heart attacks is that you have a pain in your left arm. I think you feel like one of the arms. And then you have it feels like something swaying on your chest or something, or it's like a pain in your chest. And women who had heart attacks described the symptoms differently. They were like, something's off, I don't really feel well, and
like
but they didn't have the sort of significant symptoms that you find in like books and research.
I think especially the like left arm thing and the really centered pressure on the heart was also not. It was like a general pressure. And I think, I mean, just little things like that. If medical students don't have the knowledge about that, it's not their fault. But that's going to be like that's actually
go
really
home,
dangerous. Women
are
going to die because of it. And that's why I wanted to call it the health gap, because it's really like, and that's what it's like, kind of like that's the name of it in like public discourse surrounding it. But even like, I don't know, just to tie back to what we were talking about, misdiagnosis for mental diseases, like if women are more likely to be diagnosed with depression or any psychosomatic disorder instead of actually being investigated for physical problems, then even the fact that they're not getting the correct treatment, they're getting sent home with the wrong treatment. First of all, if you're getting antidepressants when you're not depressed, that can spiral you into depression. First of all, if you're not getting any treatment, you're still going to be feeling like shit because there was something wrong. And just feeling invalidated in that way and not getting the right treatment is obviously more likely to set you up for actually developing these mental problems. So it's like a perpetuating cycle that keeps women more likely to actually have these problems and to be misdiagnosed and for other problems to be overlooked.
And it's just like, because I remember, and I know that a lot of my friends had like similar issues. So when I first started getting my period, like I got it very, like only every other month. Sometimes I wouldn't get it for like 6 months. And in the beginning, I mean, obviously it's not, I mean, you don't get it every month on the same day. And I knew that, but after a couple of years, not just a couple, like after like 7 or 8 years of having like an inconsistent period, I went to see my doctor and I was like, I think something might be wrong, because it's just, that's not how it's supposed to be. And basically all of my friends are having it every month, and it's not the same for me. What's wrong? And then she was basically like, well, yeah, you stressed, or are you like not feeling well, you know, is something bothering you? And I'm like, yeah, sometimes I'm stressed. Like there might be a week when I have exams where I'm stressed, but I've not been stressed for
like, so
8 years. Yeah.
You know what I mean?
And I mean, like, I was like, no, I don't think it's stress. I think something might be off, or and yeah, she wouldn't even consider doing a blood test or testing my hormones, and there could have been something like really, really wrong. It could have been like PCOS or something, you know. And when she retired, because she was quite old, and then I went to see a younger doctor, and she was like, the first thing she said is like, we're going to do a blood test, because that's not, I mean, I don't want to worry you, but that's not normal. It's not meant to be like that. And she said that I might be missing a hormone or something who basically releases the egg. And that could have an impact on whether I could get pregnant in the future or not. So it would quite important information. In the end, nothing was wrong, but I mean, it could have been. And the first doctor wouldn't even bother to. She was literally like, oh, you're stressed, or you're not feeling well, or I don't know. Might be some private thing that's going on.
But I think it's really, that also ties back to like people just not being, I'm not saying not being educated enough, but like the research not even there. Like we were talking about this like bikini medicine. Yes, it exists because that's the only thing that was different supposedly for women, and that's what people focused on in the past. But also even so-called bikini medicine is underfunded so much. So like even if it's seen as a different thing, also it's just like not getting researched the same way.
Because we looked into like the difference in like research funding on like PCOS, and then 3 others which I don't remember.
We mentioned endometriosis,
which were just about I think
so the trial was the comparison between different illnesses and their funding was, I think it was tuberculosis, or some type of rheumatoid arthritis,
lupus thing, I think, but I don't quite remember.
And polycystic ovarian syndrome.
I don't remember, but it was those 4, and they were about the same severity, the same
prevalence, same severity, same like potential mortality.
And just looking at the funding was like PCOS was something like
$200,000,
something like that, and then all the others were in the 600, 700. One was I think 400, but it's still double the amount that PCOS was getting funded. So it's like there is a big difference in there.
So basically, you could say that also an issue with bikini medicine is that conditions that affect women and just women, they're just not being researched.
Well, it's only half the population, and you're like, but all the research that you're doing on supposedly the entire population, you're actually only doing on men, so that's also just half the population.
I found an article that was talking about the fact that it could either be, or probably it's both, but they were saying it's probably also the lack of interest by researchers, because you just get more people are interested in heart diseases, cardiovascular like problems, all that, and that kind of research. And then also, first of all, so people aren't interested. Second, they weren't talking about the lack of charities, just focus on that. Whereas we all know the big charities, like I literally don't remember them now that I know we all know them. That I don't remember the names, but we know there's the really big ones for diabetes, for cancer, for cardiovascular diseases. I don't know any person, until I did some research, I didn't know any that were solely focused on women's issues such as PCOS or endometriosis. So because of the lack of charities pushing
like the
Women's
research. Health Initiative, but it was only developed like quite recently.
And if there's only one compared to like 10, obviously you're not going to have the same funding. And if there's also a lack of public interest because there's a lack of public knowledge, you're not going to have the funding. So it's all like this kind of
it all starts
self-perpetuating cycle.
And it all starts with, it all goes back to like education. Like I don't recall learning anything about any of this in school.
No.
Like I'd never heard of PCOS before I talked to my second doctor, or endometriosis. Like I didn't even know what it was. And I didn't know that it is quite common among.
Endometriosis is like 1 in 10 women. I think.
1 in 10 women,
and it's so under researched. Nobody knows what to do with it. It can
in certain areas of the world.
It could take
to get
years.
A diagnosis. That's ridiculous for something that's affecting 1 in 10 women.
But it was also like in certain areas of the world, PCOS is as prevalent as 21% of women, which is a lot of people. And
it's like the symptoms are so common, so it's easy, especially if people just don't know about it. It's easy to get them misdiagnosed, or as you said, just put it all on stress and be like, it's stress, whatever. You're just not feeling well this week. You're one of the unlucky people that have a longer period. So it's like easy to have like just either not get diagnosis at all or just get a misdiagnosis. And that's mainly also again lack of knowledge.
Yeah, but I feel like one thing that we didn't really mention a lot in the session, but I still think about a lot is like how people don't talk or research enough like conditions surrounding pregnancy, which is obviously something that only female bodies are going to go through, regardless if you're like a cis woman or trans man going through pregnancy. But there's so much surrounding that, like so many risks that comes with it, just going through the pregnancy, but also things such like mental issues like prepartum depression, postpartum depression. And these things are just not like they're just not researched enough and not talked about enough as being severe enough to require.
It just feels like people like women have done it for like thousands of years. Like
it's like just like
it's not that big of a deal.
Which is just really upsetting.
Yeah, it is. I think. Do you have any last concluding thoughts? We're already talking for like
I feel like
we touched upon a lot of
we touched upon the major things.
And if you're interested in finding out more, just go in and do some research. And also what I just mentioned before we're starting the podcast, there's an indie publisher in Edinburgh called Monstrous Regiment. They're really great, and they're like a queer feminist publisher, and they're doing a new anthology. It's called So Hormonal, and at the moment they're just basically collecting ideas and topics on it. So and I think they're gonna talk about what you just mentioned, like pregnancy, asexuality, transitioning, endometriosis was one of the topics that they wanted to do something on. So I think that's going to be really great and really informative. So keep an eye out for that. And that's it from us for today. And next week we're going to talk about virginity as a social construct. So apparently quite a controversial topic. So I'm excited for that. But for now, thank you for listening.
Thank you.
And have a good day. Bye.
Bye.